Housekeeping. So we have a brief presentation by Hyan Choi about racial disparities and SGSTEN, and then we're going to talk about regional networks that exist. And for the patients and families, these are the networks that really are forming the backbone of this conference, that are building repositories of DNA and clinical information of patients, and we'll hear from many of them. Each will have, so now I'm speaking to the speakers, including myself. We have 10 minutes maximum each, and at the end of that we'll have 45 minutes of time for discussion and questions that we'll have a free-form discussion, not a form discussion like the earlier panel, so you'll be able to ask any question you want of the folks that are here. And we'll pull chairs up in the front here. So with that, I'd like to introduce Hyan Choi, who's actually a Vancouverite. Am I correct about that, or did you just work here for a time?
I used to work here.
Yeah.
I joined.
Still here. Good. We don't like to lose people, so we're glad you're here. And you're going to talk a little bit about racial disparities, right?
Okay. This is how I. Thank you. Thank you, Bruce, for inviting me. My old friend and Elizabeth. Thanks for inviting me. I'm already learning a lot. Right now, my primary appointment is Massachusetts General Hospital and Harvard Medical School. I treat gout patients. I'm a rheumatologist, and I have to think about all these allopurinol hypersensitivity reaction scar. That's why I got involved in this, and then did some research, and that's how I got invited here. So I'm a rheumatologist and epidemiologist. A little bit I do health economics as well. My disclosure, short disclosure here. So this is a slide that was generated based on the national inpatient sample that represent the U.S. inpatient hospitalization over the years. And right side shows a U.S. census-based database racial breakdown. Basically, as you can see, Caucasians about 65%, and followed by Hispanics and African Americans and Asians in green color and blue color. But left side shows all those hospital patients with the SGST and as a primary discharge diagnosis, and also has a secondary diagnosis that is called urate metabolic drug adverse effect. So had to have two of those combinations. As you can see, the Asians are overrepresented compared to U.S. Census data, right side. Also, African Americans and Caucasians much lower if you look at the breakdown. Already this shows that, well, there's something going on in the all these colored folks. We do the relative risk calculation, denominator being the right side census data. Relative risk of developing SAST and hospitalization was 5 among African Americans, and it was 12 for Asians. Obviously, there are gaps, so you have to think about maybe indication is higher, that's why it is having this, other than the drug side effects as well, or some other risk factors more common there. We could not adjust for all those things, but it shows the possibility at least how this works out. And then this led us to investigate what about actually, if you can look at the, how people initiate allopurinol and how the racial breakdown happens. This is, we investigated US Medicaid data set from 1999 to 2012. And the left side, this x-axis shows the days after allopurinol initiation, and y-axis shows the frequency. As you can see, the frequency goes up around, it peaks at around 31 or 40 days. It's like a 10-day breakdown as you go through the x-axis here. And it peaks at there and it comes down near the, about 3 months time point, goes back to like background rate. So this seems to be, again, how the frequency is distributed after allopurinol initiation. Again, this is a scar after allopurinol initiation, all hospitalized with a primary discharge diagnosis of SGST. Obviously, there are limitations of that if you look at the validation study, but this epidemiologically, that you can get a picture how these things behave. So same data, shows that if you look at the risk of actually, if you look at white and Hispanic as a relative risk of 1, black people had 3 times of developing that, and the Asians 3 times, and the Native Hawaiians, the Pacific Islands, these are basically Asians, and about, in this case, about 7 times increased risk of developing allopurinol-associated scars. I created another abbreviation for you. In this case, AA scars. And this seems to reflect, again, HLA 5801 prevalence in the US. This is a allele prevalence, so maybe the carrier prevalence would be higher than this, but again, a white was about 1% or less. Hispanics, again, less than 1% in US, and Asians 7% or so, black 4%. Perhaps with a racial mix, and if you go to South Africa, it was this area is about 10% or so, and the Native American, Native Hawaiians and Pacific Island is about 6%. And other risk factors we also identified in the Medicaid database, about 2.5 times increase in females. Older age was associated. CKD, we knew CKD also. Kidney is an organ that excretes oxypurin almost exclusively, so if you have a CKD, that increases the risk of that. And lower dose allopurinol initiation was, higher dose, more than 100 milligrams per day, was associated with about a doubling of risk than less than 100 milligram per day initiation. If you combine all these joint risk factors together, reference group being young, male, low risk race. And if you are older, woman, Asian, you had about 12 times increased risk of a scar in this case, and kind of shows the dose response relationship depending on your male, female, high risk race or not. Also did BC data where we are right now, BC population data, Canada. And as Bruce described how many people live here, about 4.5 million people live here. And then data are available from 1990, and the vital statistics also available. And this is the year that we investigated, again, initiation of allopurinol. But we don't have a race variable in BC data. So you look at this distribution of Asians in these different regions of British Columbia. Richmond, I don't know if you drove through already Richmond, about 65% are Asian there. And Vancouver, about 41%, Fraser North, about 33%, and the rest of the region 4 group is less than 10%. So we use these regions as a surrogate marker for race. And about black population is about 2% or so. It's much lower than US population, probably ignorable in this epidemiologic setting. So when we did that, we find the same thing, group 4 through 3 to 1 in the region area here, compared to group 4, which was Asian population, less than 10%. As you can see, those response relationships are going up, this risk of, again, same thing, allopurinol-associated scar. And the final 3 slides, did a little bit of this, I just spoke to Cynthia Song there about the cost-effective analysis. Again, there was raised a few times during the first talk already today. So we thought that, again, different race can provide a different cost-effectiveness, perhaps, because your risk is so low. Perhaps among Caucasian, maybe less cost-effective running this, or black maybe justifiable, Asian justifiable. So first, this one says the pretest probability, hypersensitivity risk. Okay, this was, again, maybe there is this is maybe a little bit off. We might have to refine this, but generally this was the idea. You know, you will develop 1 out of 3,000 people on Caucasians, let's say, and if you have HLA 5801 positive, it will be 1 out of 189. And if you're negative, it becomes 1 out of 20,000. The idea is black people, again, this gets really very dangerous level of 37 people treatment. We'll have 1 case, Asians 1 out of 17 if test is positive, and becomes much lower. So then that's how we came up with, again, depending on the race. Again, the horizontal blue bar is willingness to pay $109,000 US dollars per quality. That's kind of the current willingness to pay. And then Asians, according to our analysis, came down. It is cost effective. Black people, probably yes, but depending on the cost of the test. In this case, our test price was $247, so it's higher than what Cynthia was saying in Singapore. But white folks was not cost effective. How about the other SGSTN per race? This is a UK GP database, CPRD database. Obviously, UK do not have many Asians like US population or black population. That's why their 95 confidence interval did not reach the significances, but compared to white, same thing, twice increase in blacks and white Asians, but this is all SGST and not connected to drug or not connected to, not only connected to drug. So all kinds, it could be infection, many other reasons of SGST, and still seem to show, again, colored people have an increased risk of SGSTN. And this is, again, US NIS, again, all SGSTN, not only allopurinol-related or drug-related. You can seem to show same thing. In this case, the thing I find it different from allopurinol hypersensitivity syndrome was even Hispanics, 20% increased risk of SGSTN. We didn't find that in allopurinol hypersensitivity syndrome. Asians overall 3 times, Native Americans about 40% increase, others also increased. That's all I have.
I think we have time for a question or two or comment. Gianpira?
Thanks for the talk. Can you just go back 2 slides
Okay.
where you showed the UK data?
Yes.
The unknown group seems to be
Unknown group, right? Yeah, unknown group is very difficult to comment. We don't know why it's unknown, and this number is big. I don't know why this is not available. This is a case control portion of that core study. It's a difficult to comment, looks like.
So maybe I can help.
Sure.
So I work with the CPRD database.
You do.
We don't normally collect ethnicity data in CPRD
Yes.
practices. We are, so there are suggestions we should be collecting that. That's very important. But at the moment it's not collected. That's why it's unknown at the moment.
Mm-hmm. Thank you.
It's quite a large group. Education is generally representative of the population. If anything, the odds ratio should be 1 or above, right? So there are some confidentiality issues, and people will have, that's because of confidentiality issues. People will just, it's easier for them to put it unknown at the moment. So I think there are many major issues into data protection, confidentiality.
It's intriguing, as you are alluding to. Why would it be?
Is there any association with socioeconomic status or data like that? Because we think of disease as a gene-environment interaction.
Right. Yeah, that's a good question. I was suspecting Medicaid. We looked at the insurance status and the SGSTN. One of the papers, Hugh et al., didn't seem to associate with the general SGSTN. When you look at the allopurinol associated, we couldn't find that based on Medicaid, Medicare, private insurance. So unclear, but that's likely as we have. Yeah.
Thank you very much.
Thank you.